All right, good morning, everyone. Hello, thank you for joining us. My name is Elizabeth Thompson. I'm North Carolina Health News' reporter covering gender and prison health. We're joined today by two amazing panelists. Tommy Green, lead community health worker for NC Fit, a program that connects people leaving incarceration to free healthcare and other reentry needs, and also co-owner and creator of Success While in Transition. We also have Essence Hairston, the program director at UNC Horizons, a program that treats women with substance use disorder, including those who are coming out of incarceration. Thank you both so much for being here today. So I think we're good to get started. So let's start off with an easy question. We talk a lot about reentry for incarcerated people, but what do we mean and how is this a health topic?
Yeah, I think this is a really important and a good question, Elizabeth. When I think about health and reentry, I think we would do a disservice if we didn't recognize health outcomes for those transitioning out of jails or prisons, specifically working with pregnant and postpartum patients impacted by substance use incarceration. The first thing that comes to mind is health insurance and benefits. So individuals can enter into jails or prisons, and at that time may have access to insurance. But then upon release, they automatically lose their health benefits. And so that also lead me to dig a little deeper, define health in terms of reproductive health, as well as social determinants of health or social drivers of health, and how all of those things impact the overall well-being of individuals transition out of incarceration settings.
Definitely everything as said. I would only add a lot. Reentry looks like a lot of things for incarcerated people. Reentering society, rebuilding themselves and their lives, reestablishing themselves, reestablishing relationships with families. And another thing, and when it comes to healthcare or it being an actual health topic, the only time you have a constitutional right to healthcare is once you're incarcerated. But the thing about it is once you're released, you have absolutely no rights to healthcare, of course. And also, this population of people is the most vulnerable population of people. So when you add in the fact of them also not only dealing with surrounding reentry or all the barriers surrounding reentry, when you have a person like the people that we help with the chronic condition, that compounds every other barrier that they have. And it's a handful for anybody reentering society. The healthcare system is a handful to navigate anyways, but just imagine that on top of, again, every other barrier you have to face upon reentering society.
Yeah, definitely. And when we talk about reentry, it's kind of just like this vague topic. And it makes me think about, how long is reentry as a concept for people who are coming back from incarceration?
So reentry is kind of individualized as far as how long. It could honestly be a lifelong situation, especially dealing with what we like to call collateral consequences of incarceration. Things like not being able to vote or not being able to hold certain jobs or not having access to certain social services because of your charges. And these are some of these things are like lifelong bans. So again, reentry could impact someone for life. I use myself an example. I'm a formerly incarcerated individual myself. And I've been home now a little bit over 6 years. And yeah, I have a decent job, work for the health department, government job, so on and so forth, have my own business or whatever. But even me, I still have barriers that I have to face. I'm a convicted felon. That's a lifelong tag. I still can't get certain licenses. I still can't get certain certifications. And here I am, a government worker. Even with rent, I can't rent in certain places. Thank God my mother was willing to rent her house to me, or, who knows where I would be right now. So it's a lot.
I think Tommy said that beautifully, and I echo everything that he mentioned. Reentry is long-term and lifelong, and it's also individualized because, similar to what he was saying, thinking about those social drivers of health, social determinants of health, individuals that are leaving jails and or prison are least likely to have secure and safe housing, have access to transportation, childcare, nutrition, and again, health benefits. And it takes time to, even if those items are available to them, it still takes time for those things to happen, given the scarcity of housing in general. So in employment, so it definitely takes time in terms of reentry in that journey, in that process for sure.
Mhm. Yeah, definitely. To all our viewers, we are tuning into Healthcare Half Hour. It's hosted by North Carolina Health News. We cover all things health all over the state. So if you want to read more, you can subscribe to our newsletter, and you can find that link in the chat. Our social media guru will be putting that in soon. Essence, you said something, mentioning prisons and jails. I think a lot of people don't know the difference between prisons and jails. So what are the differences, and how is reentry different for people reentering from prisons versus jails?
Yeah, I am so glad we're talking about this. Oftentimes, individuals will use those terms interchangeably, jails and prisons. Historically, a jail is what we would consider maybe a holding spot, maybe somewhere before trial, or maybe short-term sentencing, whereas prison is typically for those who may have already received their sentence or waiting a space at the facility that they will be transferred to. But for pregnant patients, because of their pregnancy status, when someone enters into the local jail, they are transferred to the women's prison here in Raleigh. And because of the women's prison here, they have a medical unit, a medical facility to provide the prenatal care as well as the medication for opioid use disorder. And so when we're thinking about on a local scale, let's just say the local jails, that's one system. So we're navigating trying to get someone into treatment. But then when you have that transition to the prison, now you're having to navigate two systems. So thinking about barriers and challenges for those seeking treatment and wanting treatment, it could be 2 to 3 weeks for someone that's in jail, depending on the bed placement, bed availability. But what we're seeing when individuals transition into the prison, that's typically 3, 4, and sometimes 6 months of delay before someone can get into treatment.
Yeah, Essence hit that on the head. The biggest difference is really just the time, the length of time, and how that equates to like more issues for one other as opposed to the other one. For instance, a person, doing like jail time or just going to jail, they essentially still kind of like have a chance. They have a shot to kind of like not miss out on too many things. Heck, they might not even their charges might not even stick, and they might not even be convicted. And the difference between someone coming home from prison is that, if you're in prison, of course, you had an actual sentence, you were there a length of time. And so when you come out, things like, if you were on Medicaid or you was getting government assistance, those things are suspended. And a lot of instances, it's hard to even get them cut back on or restarted, as opposed to coming home from jail. I mean, doing a jail sentence, you're subject not to even be there long enough to even miss out on any of your benefits. So have to try to worry about getting back on Medicaid or so on and so forth. So really, again, the biggest thing is just the lapse of time. Also, keeping in mind with our substance use, people that are battling substance use disorder, one thing about the reentry population, they have a higher risk of overdose in the first 2 weeks of their release. And one of the reasons why they overdose is because they've been incarcerated so long that their tolerance has gone completely down. And when they come out, they think they can go back to using the same amount of substance that they did before they were incarcerated. And it's just too much. They overdose and die. People in jail don't typically have to worry about that. Again, they're not there very long. I hate to say it, but they'll come out and get right back on something and no damage is done, no more than what's already done by using the substance in the first place. I know that's kind of like a catch-22 comparison, but it's reality.
And one of the things that I do want to also acknowledge is that pregnant patients that transition from that jail to the women's prison, those individuals are typically not convicted of a crime. And so they are specifically housed there based off of that pregnancy status. And so for someone that is non-pregnant, could actually maybe serve their 30-day or 90-day condition or CRV sentence within their local jail. Unfortunately, for a pregnant patient, they are transferred to the prison where for those who are typically, again, sentenced or convicted. And so they are there despite their conviction status.
Mhm. Yeah, that's definitely something that I think a lot of people don't realize. Tommy, you're a person with lived experience. You mentioned that earlier. How does that help you do your job in connecting people with resources?
In one word, I would definitely say tremendously. The commonality that I have with my clients really makes our service a lot better. To kind of put it in perspective for our academics that on the line that have no lived experience, whatever, with incarceration that is, it's like when you go to a school and you bump into somebody from your hometown, you kind of gravitate to them. You might ask them, where's the mess hall, student lounge, so on and so forth, and you'll let them guide you and be comfortable with that. That's the same like situation when it comes to how I deal with my clients. And not only dealing with my clients, but in dealing with people in life, period. I always kind of like introduce myself first, kind of like, let them get to know me, try to impress them with a little bit of my personality, things of that such. And then, I'll drop the bomb on them. I was formerly incarcerated. I actually did 12 years, so on and so forth. And I do that intentionally because I don't want people to just judge or look at me as just someone that came home from prison and got himself together. I want you to look at me as a man that has got himself together, that just so happens to have went to prison. So anyway, and putting that in perspective of how I deal with my clients, it's like when I'm first talking to them, when I'm giving them the spiel about NC Fit and the importance of healthcare and this, that, and the third, I feel like they're kind of taking it in, they're listening. But when I drop that bomb on them and let them know, hey, I'm also formerly incarcerated, it's like their shoulders drop, they relax a little bit more. Now they're really receiving what I'm saying in a whole nother light, because now I'm not just a healthcare professional trying to give them a lecture on their healthcare. I'm a healthcare professional that's been where they have been, that knows what they have to go through to be successful. So they kind of like, that gives me a rite of passage, or for lack of a better way of saying that, to point out things to them, and to also kind of like verify the staff that they work with. Our director is also my primary care provider in Orange County. And, he's an older white guy, wears glasses, looks like the typical doctor type, and these people are a little bit, even though he's a doctor and that's his area, that's his uniform, I think this population of people still sees everyone the same. If you're in a uniform, you're a person of authority, you're a person that can't be trusted, so on and so forth. But if you got me, now I'm considered like the big brother, the cousin, the homeboy, the father figure, or whatever. So you got me saying, hey, this guy is like not only the primary care provider, he's the director. He's really passionate about this work. He really wants to help people like you. You can trust him. And then once again, there's those shoulders dropping again, and now they can ease up and be completely and totally honest with our providers so they can get the best health care that we can provide for them. So that's kind of like what that looks like. Again, I would never take away from none of my academic brothers and sisters, but it brings a whole nother element of comfortability and commonality when you have someone in position, or at least a buffer between those two, that have that lived life experience.
Wow, Tommy, how do I go after that? I just want to validate and honor everything that you just shared. I think it's so important for us to think about, when we think about experts, when we think about experience, what does that look like? And recognize that everybody comes to the table with something. So here at Horizons, we believe in an interdisciplinary approach, interdisciplinary team. And, Tommy's absolutely right. Individuals with lived experience, whether it's substance use recovery, history of incarceration, they bring a different perspective and knowledge for other folks who may not have witnessed or experienced those systems. And so it's so important when we're thinking about not just individual direct care, but even when we're thinking about policies and community efforts, who's really in that space and who is really driving those initiatives, because it's so important to have individuals with lived experiences. And I think it actually makes programs more effective when individuals with lived experiences are onboarded and in positions to lead, because they know what is needed. And so I value and honor everything that Tommy just said, and also value differences of experience in education, because it's really important to do this work.
Yeah, absolutely. I'm just going to take 1 minute to plug our current fundraising campaign. North Carolina Health News is free to you, but it is not free to produce. In order to support our award-winning journalism, you can donate to our fundraiser for Newsmatch, which is in the chat. If you haven't signed up for our free newsletter, you can also do that in the chat. Once again, we have these great monthly healthcare half hours every month. Thanks again to our experts for being here as we're continuing to talk about reentry from incarceration. As we're talking, we had talked a little bit about UNC Horizons and NC Fit. They're both really great programs, but they also can't scope the entirety of North Carolina. So how has meeting that need been a challenge for the two of you?
You want to go first, Essence?
Yeah, absolutely. So what I'll say is that, the gaps existed prior to the pandemic. And so with the pandemic, managing the treatment of an epidemic, the opioid epidemic, within a pandemic, the gaps of treatment and access to treatment reduced significantly. Providers either had to discontinue services or reduce the amount of services that they could provide because of the in-person and then quick transition to a telehealth model. And so thinking about things across the state, I think the pandemic kind of highlighted even more the need for increase of services. And so I know there are a lot of programs that's doing a lot of great work, but then when we get to the specific target population and treating for Horizons, again, it is a very defined pregnant, postpartum individuals with substance use. And when we're thinking about resources specifically for that population, there is a need to somehow expand on those resources. And then, of course, add on that intersection of incarceration, separation from caregiver and child because of delivering in the prison. It is, I heard someone say it takes a village to raise a family. And I think it's going to take, the state of North Carolina to really come together to support this village, the population that we believe in, because I think we will see, the long-lasting effects of the pandemic, even as individuals transition or, consider this now as a new norm. So yes, there's significant amount of gaps in treatment, and there's a need to fill that throughout the state of North Carolina.
Mm-hmm.
Well, that's a tough act to follow as well, Essence. You just raised the bar. But I totally agree with everything she just said. She hit the nail on the head. First and foremost, I would definitely say I feel like programs like Horizons and NC Fit, we're covering a lot of ground. We do a lot for our clients, do a lot for the community, but at the same time, it's not enough Fit programs and it's not enough Horizon programs to even probably cover half the gaps that we're seeing right now. And like she said, you know, COVID just COVID just really like changed everything. And definitely not for the better. It really like made our jobs a lot more complicated, especially dealing with this population of people, because first and foremost, once COVID hit, everything went to Zooms, videos, tech, everything went technology, straight to technology. And this population of people, a lot of them are not tech savvy at all. A lot of them haven't even been here. They were locked up before Zoom was even Zoom, you know. So with that being said, that proved to be a challenge in itself. And like right now, everything still is not back to nowhere near normal. So again, like the already existing problem got bigger and got greater. And it really challenged us to think outside the box and create other programs. Like for instance, we started a program called Fit Connect to help the guys that DPS saw as a vulnerable population during COVID and let them and release them early. Fit Connect was a program that kind of helped connect everyone in North Carolina that was coming home on that program, which was called ELC, I think, extended leave of confinement, right? So yeah, again, it's just very challenging, and all I can say is we just gotta just create more programs like these. You know, that's the answer. That's definitely evidence-based programs, and we got the numbers to prove these things work.
Mhm.
Better way
Yeah,
to say that.
definitely. And also, as we're talking about these programs, we know that this year Medicaid was not expanded. And I know that's something that some advocates for people coming out of incarceration have been hoping would happen, just because as we're talking about these gaps, that would fill some of those gaps. Going forward in terms of connecting people to insurance, what really are the options?
You want to go, Essence?
I'll take a shot at this. You know, that's a really hard question to answer, to be completely honest. You know, for individuals, we'll say, so our program specifically works with uninsured or individuals with Medicaid. So someone who is transitioning out of a jail or prison, it can still take about 30 to 45 days before someone can get their Medicaid reactivated. And so there's a lapse of continuity of care, prenatal care, primary care, reproductive life education and counseling, and access to contraceptive care, as well as prescriptions, medications for opioid use disorder, etc. And so I don't know what that will look like, but I know that for Horizons, and I think I could speak for Fit, those are things that we're willing to do. So despite someone's health insurance, they still have access to our primary care provider, our OB provider, at either clinic. We partner with Waitebrook, we have a provider there. And then we also have a integrated OB clinic in Chapel Hill. And so we are seeing individuals despite their health benefits, but not every program, healthcare, outpatient, primary care setting can do that. And so Medicaid expansion definitely would have helped this population significantly. But, you know, I think we do the best that we can with the resources that we can while continuing to advocate for this need. But I don't know what that looks like, Elizabeth. I think it looks, doing what we've been doing and, trying to find resolutions just to meet the needs of individuals, and then working with other community stakeholders to also support those efforts.
Same. Our clients don't have to have insurance as well. We actually provide. We actually have a little bit of funding to cover their co-pays and most of their prescription costs. But even us, we don't have like the funding to cover like specialty care or anything that's like really expensive. So what do we do about that? We actually kind of connect them with other resources like charity care or med assist or something like that to help with those costs. But again, like us being in this non-expansion state really hurt us as well. You know, our population of people won't qualify for Medicaid once they're released, and that's like a tremendous barrier. But again, not now. Fit is not no insurance company, but we kind of like cover a few things that cover the things that we can, that is, and kind of help out with those who can't. We also, you know, as part of that comprehensive plan that we help put together, that's one of the things that we also help our clients with, you know, seeking social services, the ones that do qualify, Medicaid, so on and so forth. We help them apply and things like that. But that's probably the extent of what we can do without, you know, being an expansion state.
Mhm. Yeah, definitely. I just wanted to note that because Essence works often with pregnant people who are more likely to be covered by Medicaid rather than just people who are coming out of incarceration who may not be pregnant or have an underlying disability that would qualify them for Medicaid. So if you heard her talking about Medicaid and you're like, why is it that Tommy's patients can't get Medicaid? That's why. Just for people who don't know. We are getting close to the hour mark. Just asking, do you all have just a couple of minutes to answer maybe one or two questions? Is that all right? And if anyone has questions, if you could put them in the chat right now, we could probably answer one or two, and whatever we don't get to, I think Shelby has put my email in the chat. Feel free to reach out to me. Shelby, do we have any questions?
Yes, there were a couple. I think a couple y'all actually addressed as we went through. The very first one comes from Matthew Isley. I'm sorry, no, from, can you speak a little bit more about access to healthcare post-release, which I think y'all covered a lot of that. This is from a researcher looking at Medicaid expansion in different states, which good. Sorry, scrolling back through. Sarah Hoffman says, in case there's time in working with reentry individuals, what types of differences, if any, do you see in the barriers they face to accessing mental health versus healthcare services versus other types of healthcare services?
That's a very good question. I think access to mental health services, I want to say it's a little bit more ready available, at least in this area. You know, we have like Freedom House. What's the other one? I'm drawing a blank right now, but it's a couple of places that people can just walk in and get mental health assessments, and if they qualify, that entity will take them in and work with them, so on and so forth. But you don't really have no place like that with healthcare. The best you can do is walk into a federally qualified healthcare center, and maybe get on a sliding fee scale, which, you know, you still have to pay something. And yes, some of those fees can, I think, go as low as like $25, which doesn't seem like much. But when you're dealing with a person that's coming home to absolutely nothing, even that could be a potential barrier. But and even on the flip side of that, you can also get like mental health care services through an organization like that as well. But again, you're still dealing with a sliding fee scale that someone may not be able to afford. So it's a little bit more accessible, at least in this area. I can only speak on Orange County. I don't really know too much about the any other county, but around this area, it's kind of readily accessible.
I think it depends on population. I specifically work with pregnant postpartum and parenting individuals with substance use. And so just thinking about the gaps to comprehensive treatment, where we're not just treating substance use, but we're also treating the emotional, cognitive, all of the parts of individuals to promote long-term recovery and healing. But I think there's only a few of us in the state, a few programs in the state. We did our annual crunch numbers at Horizons, and there's about 565 screenings and referrals for our program within the last year, and we can only house 30 families at a time. And so I think in terms of mental health, and in terms of like the population, I think that definitely looks different because those numbers are very different for non-pregnant patients in terms of being able to access care. I will say that historically, we only focus on physical health. And as we do advance more to having those integrated models with behavioral health, I agree with Tommy. I think there's a lot of movement, education, and awareness about mental health and behavioral health. But also, again, just taking that a little bit deeper and thinking about those social drivers and social determinants of health. And so not just looking at physical, emotional, mental, but what are the other factors in play that can maintain somebody in long-term recovery, whether it's for their physical health, substance use, or behavioral health. And so I say this not to be so tangential, but there can be some delay given availability when working with pregnant and postpartum individuals with a substance use disorder.
Yeah, we did have a question from someone who wanted to ask their question. Patrick, you can go ahead.
Thank you, Elizabeth, and thanks for letting me join in on this. It's been quite helpful for me, as I said in the chat, as a human, and secondly, as a journalist. And I've been impressed by everything everyone has had to say. But Tommy, hearing you speak, I kind of wonder, with sort of the gaps in so many areas, from insurance to getting on your feet and finding some level of success as a human being once you leave prison, how much more helpful do you think it would be if the people who are leaving prison have someone like yourself who can sort of guide them, versus however many there are right now doing the same thing you are? Because I imagine that there are a lot of people who are doing all they can, but they cannot relate on the same level as you do, having experienced, I believe, 12 years on the inside.
Right. I think it helps a lot, to be honest with you. I'm not just saying that because I work for a company that has this model, and this is my job, so on and so forth. But I'm really seeing like the difference between a person that's working with someone with that experience and a person that's not. Again, a person that's been there, done it with that lived experience has a whole different level of insight. Even have what we call tricks of the trade. You know what I mean? Like, we could, like, for instance, one of the things that me and my partner teach through Success While in Transition, through our business, is that we teach people that how to use the survival skills that they had in prison, how to transfer them over to essential skills to survive out here in society. And teaching people things like that, that's just something that a person without lived experience cannot do. And also too, this population of people they're coming from a place where they've been mistreated, for lack of a better way of saying it, always been looked down on. They're surrounded by a lot of stigma with people reentering society. And so they come out on guard. They come out with their defenses up. And honestly, in a lot of situations, it takes a person like me to bring those defenses down, because they've been surrounded by people like me for so long. We're the only people that they really trust. So with that being said, again, dealing with people with lived experience in the same area of the actual client, it's the outcomes have been phenomenal. We actually took this, well, not took this one. We designed FIT behind a organization called Transition Clinics Network out of California. They're the ones that actually started this whole formerly incarcerated people being community health workers to work with other formerly incarcerated people. And before they got started, they pulled a lot of formerly incarcerated people and asked them, you know, what's the most beneficial way for us to get through to you or us to help you with your health care? And unanimously, hands down, they all said they wanted to work with someone that has been there and done that, not just someone that knows this life from a book, you know. So you have it straight from the horse's mouth. Like, this is how you get through to people, letting them work with people that are just like them. Did I answer your question, Patrick?
Love and beyond. Thank you.
Well, thank you. Oh, sorry, Essence. Did you want to say something?
I just want to add one thing. What Tommy provides and other individuals with lived experience, what they provide is hope. And hope is essential to healing. And so everything that Tommy just shared is so true. There's again a level of experience, but also a level of hope that comes from that work, that partnership, that alliance, that is indescribable and really important for every agency working with different populations. And so I just want to honor and thank you, Tommy, for the work that you're doing and the hope that you provide, because it is really, really important.
Thank you. I'm glad you mentioned that too. That's a very good point. It's always a, if I can do it, you can do it situation when it comes to working with my clients. I'll tell them quick, look, I was incarcerated for over a decade, you know, and look what I'm doing now. If I can do it, if someone will give me a chance, someone will give you a chance. And that's like phenomenal, especially to people that haven't done as much time as I did, or their crimes wasn't as severe as mine. That really gives them hope. Like, man, he did this and he was there for that long and he's doing this now. I know I can do it, you know. So thank you, Essence, for pointing out again.
We have one more pretty interesting question here from Virginia Cleary. What role does a parole officer have in this realm? It seems like the parole officers could be trained in connecting people with resources. Do y'all ever interact or train them?
Not necessarily trained, but we do interact with them all the time. The parole officer, they're a key piece to working with our clients as well. You know, we have great relationships with parole and probation. We work together sometimes and make referrals together, depending on the client's needs, mostly substance use, disorder or whatever. They have a little bit more connections than we do. So sometimes we'll revert back to them and vice versa. They'll revert to us if they need direction for one of their parolees as far as any type of healthcare, mental health, so whatever. So it's a I'll scratch my back, I'll scratch your back, you scratch my back type of situation when it comes to parole officers. And it's definitely beneficial. Heck, we even advocate sometimes to the parole officers. I've kept a couple of clients from being violated, and I'm pretty sure that was a tremendous help for them.
Agreed. So parole officers are typically for individuals who may have completed their sentence, so they're transitioning out. And probation officers who we typically work with, they're more so like pre-sentencing, so to speak, thinking about it from like a, I don't want to say pretrial services, but some community intervention efforts for the courts. And so we do work alongside with probation officers here to, again, reduce that jail to prison transition, that pipeline, and has been really successful in terms of talking about trauma-informed care, substance use treatment. Discussing incarceration is not a form of treatment when working with individuals. And so they are invaluable to us. So when we're thinking about interdisciplinary teams in terms of health, right, we also need to include the local sheriffs, the probation officers, the pretrial coordinators, because like Tommy said, they're very beneficial into who access treatment and also who gets to maintain treatment, so to avoid disruption in services. So yeah, I totally agree with what Tommy mentioned.
Well, we are way past the hour, so I'm gonna wrap us all up. This was such a great conversation, though, so definitely worth going past a little bit. Thank you both so much for all of your insights, and thank you everyone who came and watched today and asked your questions. We really appreciate it. Once again, this is for North Carolina Health News. Follow our newsletter, and we are doing a donation campaign right now, which you can find also in the chat. We appreciate all of you coming in today, and thanks so much.
Absolutely. Thank you.
Thank you for having me. Thank you so much.